thank you all for having me here. Thank you for inviting me, and it's just so fun to be here. That was in October this last year, right in the middle of all the pandemic stuff, so it was a little bit crazy. So just really glad to be here. And yeah, so there's a couple of things I wanted to talk to y'all a little bit about today. And kind of the thrust of what I wanted to go over was kind of maximizing efficiency and going over some workflow information. And what I want to say too is before we get really going is that I'm in there with you guys. So I'm a prosthodontist. I finished in 19 from Texas A&M, and basically, you know, I'm right there with y'all. I do all of my own lab work. Sometimes I'll have somebody come in and help me process, but that's basically it. I do all of my own impressions, all my own setups, all my own wax ups. For fixed, I do literally everything. So I do all my scans, designs. I outsource for the milling because the milling machines are very expensive. But I do outsource milling to a local milling center. I get it back, do all the porcelain and glazing and staining. So I'm going to talk a little bit about that today as well. But this is a view of my laboratory, my plaster station. And then this is kind of my 3D side. So I have two 3D printers. And then I have an IVA-based machine and a porcelain oven. And then I use, on my computer here, you can see I use Exocad almost exclusively for my computer work. Whenever I'm planning implants, I'll use Blue Sky Bio or Blue Sky Plan, and so I pretty much do it all. So I also like to use. I threw this in just to show, like, I really like having flow and efficiency. So whenever I'm working, I have two operatories built out, and so whenever I do my work, I basically have a cart that has my little diode laser and then my Trios scanner. Or I have my surgical cart here that has my implant motor and some implant or some surgical equipment. I have a nitrous on a cart, and then we have just the miscellaneous tools cart. I also come up to Dallas every once in a while. So every other Thursday I go up to Dallas and help out at a general dentist's practice to place and restore implants for him. So I can just load everything up in this little Milwaukee tool chest and keep it rolling. So I like to have flexibility, and I like to have the ability to just change things on the fly, and that really maximizes my space and my efficiency. So I want to talk a little bit about full mouth rehabs today. So what I'll go over is kind of my flow, how I do my workups, how I do my planning, how I execute the treatment, and I'll show a couple of tidbits as we're going through there. So I have a lot of fun. The key lessons to take away, so kind of dividing into several different areas. The planning is the most important, obviously, because if you don't have a proper plan and if you don't have a proper workup, nothing's going to work. You know, your hands can move and you can restore and you can make restorations, but as long as if your planning is way off, then this is not going to work. And so this is what I think in the technician world. I think technicians are oftentimes very underappreciated because as a dental technician, you have a very big hand in the planning. And so one thing that we oftentimes take for granted as dentists is, like, we send off to do a diagnostic wax up and it just comes back. But unless you're really on point, you as a technician, you're kind of having just to guess. And so I'm going to show you a couple things that you can ask for from your dentists in order to make your job a lot easier whenever you're doing your diagnostic wax-ups and you're helping these dentists plan their cases. So we have our planning, we have our preparations, we have our impressions, we have our provisionals, we have our articulation or our occlusal registrations, and then we have our materials that we finish out the case with. And so materials, that's also where you guys come into play, and where I do a lot of my tinkering and work is on the materials. So which material is the appropriate selection for this or that case, and so that plays a big role in finishing out the case. So let's talk about planning for a full mouth rehab or for a single arch rehab. The main thing is to develop a plan that is both flexible and adaptable, because as I tell patients, before we start, I say, if everything goes exactly according to plan, you and I are both going to buy lotto tickets, Because inevitably, whenever you start working on somebody or helping somebody and going through a treatment process, there's going to be something that you're going to have to adapt to on the fly. And so that's where a lot of expertise comes in, is to be able to tell somebody or to help somebody out, like, hey, this didn't go exactly the way I wanted it to. This is how we can circumvent this, and how we can either compromise or we can make this ideal by doing this or that. And so in your planning, the first thing you do whenever the patient walks in the door is you start looking at the patient and you start doing some planning in your head. So as you start out, and with these next couple of slides, basically, you want to try to categorize each and every different item of the plan, but eventually it just starts to flow, and it'll eventually just get, where it's subconscious in your head, and you'll just start looking at things and looking at people and looking at their diagnostic casts and looking at kind of where they're at, and you can start to formulate plans. Just the gears are turning in the back of your head as you're studying the patient in the chair. So, you want to look and see where they are medically. You want to look at the aesthetic analysis of the patient. You want to look at their teeth themselves. You notice aesthetic analysis comes first, and the tooth analysis comes after that, because you want to develop a global diagnosis or a global plan or a global aesthetic workup before you start thinking about the trees, right? So don't miss the forest for the trees. And then you look at prognostic, and you analyze prognostic factors. How long is this going to work? How long is this going to last? Is this patient going to break this? Is this patient going to be able to clean this? And so there's a lot of prognostic factors that you want to assess before you start as to whether or not this is a good treatment plan. Patient willingness as well. So you have the patients who work full-time. They can't take any days off, and yet they want you to do a full mouth rehab on them. Sometimes these patients don't really realize how much time that takes. It's, basically, and I'll talk about this, it's 4-hour prep appointments at a time. It's coming back for if a provisional comes off. It's doing like a bespoke try-in. It's doing all of these appointments, follow-ups, especially with removable prosthetics, all the follow-ups and all the appointments. People think that they're going to be in and out in 2 appointments, and that's just simply not the case. So you have to make sure that the patient is willing at the same time. So from a medical analysis, you have to look at systemic factors, and it's more dramatic. You guys see diagnostic casts and pictures, but it's really dramatic whenever you actually see in the mouth what's going on and talk with the patient. And you have to ask yourself, from a medical perspective, how did this patient get to where they are today? Do they have a history of cancer? Do they have a history of chemo? Do they have a history of radiation? Do they have a history of multiple surgeries? Have they been in the hospital before for extended periods where they didn't have access, or they had other things going on than to think about brushing their teeth, right? So were they in a dire emergency, and was this kind of on the back burner? Do they work in a profession like this gentleman here, where he's sitting on a like a jackhammer all day? So he's sitting there on a jackhammer in like a machine shop, basically, and just like chattering his teeth. So these, so that's when you try to flesh out how this patient, or what went on in this patient's life to get them to the point where they need to come see you for something that's extensive. This patient here was, talking with him back in the 90s, he was like a CFO of a major telecom company. And, you'd look at him and you'd say, man, that's like a drug user. No, he had chemo and radiation. And he got to that point within like a year. He had like perfect teeth all the way, until he showed me pictures too, because I didn't believe him at first. But that's in the space of a year, he got to this point here. This patient here was a young lady. So this lady is only like 38 or 39, and she just had really bad PFMs, and eventually they just wore her teeth all the way down. So this was maybe about a 5-year process to get her to this point here. And so you always have to ask yourself, what caused this? Usually in my world, it's either xerostomia or bruxism that causes the main issues. So I do spend a little bit more time fleshing out, medical conditions as well, because they do make a difference. If you're going to do a metal resin hybrid on a bruxing patient, probably might want to rethink that, or look for ways that you can protect that metal resin hybrid from breaking. If you're going to do a full mouth rehab on natural teeth and the patient has severe xerostomia, you might want to start thinking about, okay, can we get like a cholinergic agonist? So recommending something like a pilocarpine sucker. Or is it going to even be worth it to do fixed restorations on natural teeth? You don't want the patient to pay all that money, go through that period, go through all of that stress and work on your and my end in order to just have it fall apart in like 5 years, right, or less, if they're highly xerostomic. So that plays a huge role in the conversation that you open up with this patient before you even talk about what they need. And with your aesthetic planning, and I know everybody has, somebody who has really nice teeth, but you need to get a picture when you're starting to do your wax ups and starting to do your workups. You need to get a picture of what somebody with nice teeth looks like, and then that's what you want to start working on and working towards. Nice zeniths, nice tooth proportions, nice arrangement of the teeth, and so this is like a younger female, and happens to be my wife who's here. Shaking her head. But you need to find somebody with nice teeth, and then that's what you start to emulate and work towards. This is something, I keep a photograph on my computer, right, of a nice arrangement, and that's what I start to work to whenever I'm doing my planning. How do I get from the way that the patient walks in to something like that? And so, you need to start looking at the aesthetic references. We start with the face and the proportions of the face, but really, you start looking at the intraoral presentation. So you look at the smile, you look at the repose photograph, and then you look at the retracted to see all the other different factors. So these are two photographs, the two main photographs that you need to ask your lab or your dentist for, and that I use in my planning is going to be the smile and then the repose position. So with the repose position, which is that upper right-hand corner, what you can do is you can start to establish, hey, where do my incisal edges need to be? You can look at classic literature from specifically Vig and Brundo, 1978, where they looked at the incisal edge position of men and women, all different ages. And they basically found some very specific parameters. So for men, it's usually a 0. Incisal edge is usually right in line with the lip at the repose position. And then for women, it's usually +1 or +2 up until age 40. Okay, what's the difference in the 2 millimeters? Men have a slightly thicker lip or a slightly longer lip. And then after age 40, what happens is you lose the elasticity of your lips, and so that lip starts to droop, 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 droop. You've all seen the little old men where all you can see is their lower incisors. That's why. It's their upper lip has drooped over time. So after age 40, for each decade, the rough estimate is that you lose about 1 millimeter per decade on your incisal, your repose position. So you look at the proportions of the teeth for this particular patient. The actual proportions, if you filled in where he had worn down the corners there, the actual proportions were pretty much okay. You look at midlines, and so you look at the facial midline, and that's typically what we use is the interpupillary line here, and then it's right in the middle of the pupils. Because if somebody's eyes are off one way or the other, or if they're spaced, then they have some sort of a cranial developmental problem that's going on. So typically what I'll do, and I didn't put these in just for HIPAA, but what you want to look for is your interpupillary line, and then you make a line right in the middle of that, and that's how you kind of assess where the dental midline is on the maxilla. You also look for your midlines as they go interdentally, so the maxilla and the mandible, you want to make sure that those are, look to see what the relationship of those are. If they're off, maybe that's some sort of like an occlusal, aberrancy where they're biting and their centric relation is off to one side or the other, or maybe that's just how they were orthodontically. And so you start to look at those kinds of things. This guy, 1/2 tooth off, not a big deal. You look at the aesthetic planes. So you look at your Camper's plane. That's the main one that I look at. We all use that for removable prosthetics. So Camper's plane is a line that's drawn from the ala of the nose to the tragus of the ear. There's been research done where they actually divided the tragus
up into 3 different sections and calculated, which one of the 3 different sections was the closest. I'm not that crazy about dividing the tragus up and measuring this on these patients, but what you want to develop is kind of a nice flow upwards back where the incisive or the occlusal plane should be, and that's a really good diagnostic indicator there. The incisive plane is a line that's drawn on the tips of the teeth as it relates to the lower lip. Sometimes that's called a smile arc, and so that's very natural, and literature has shown that if you have different arrangements of teeth versus lips, the most natural and the most pleasing to lay people is to follow the outline of the lower lip. Even if the lower lip is off in some direction, so if it kicks up superiorly on one side, they actually say that the teeth should actually follow that as well. So it's a little bit strange, but following the natural curvature of the lip is a really nice way to get your anterior aesthetics where they should be. And then you want to look at periodontal aesthetics. So we see some recession here. This guy actually, I think he's a truck driver, so he dips chronically. So that would explain that there. Told him ahead of time, not too much I can do there. But you start to look at your periodontal aesthetics. You start to establish, hey, do they have a thin biotype? Do they have a thick biotype? That makes a difference in your treatment planning as well. And then for the extraoral planning here on our aesthetic analysis, this is showing the Camper's line. So this is just a Fox plane that you can put in. You can either use that with a bite record to transfer to the laboratory, make some marks on the casts, or you can just take some pictures and look and make sure it's about where you want it to be. And then this is obviously the classic tongue blade with having the patient go through several different motions in order to look at their occlusal vertical dimension. So I want to say this too. I know we have removable and we have fixed laboratory technicians in the house. This patient looks like it would be a removable patient, but actually I do the OVD analysis on fixed patients as well, because it doesn't matter if they have teeth or not. Their occlusal vertical dimension of rest is going to be the same if they have teeth or if they're missing teeth, right? And so if you have a wear patient, that's very critical to establish what their vertical dimension of rest is, because if they've worn their teeth down really fast over the period of like a year and you see spaces in the anterior, like an open bite type situation, but there's still wear, that means that patient has lost tooth structure faster than the teeth can super-erupt. That super-eruption is called dentoalveolar extrusion. And so what happens is you have the patient, they'll wear the teeth down real quickly and their jaw muscles and their super-eruption does not keep the same vertical. That's the classic wear patient that comes in and they look collapsed. So they come in and they have the angular colitis or they have the drooping corners of the lip. They look, like Benjamin Franklin, with the little, the posturing forward, and they become a little bit more class 3. And so that's when you just go in and do a real quick, hey, lick your lips open real wide, put your lips slightly together without touching your teeth. That's how I measure VDR. And then you go in and say, hey, just say M and hold the M, and your tongue blade comes up and you measure. You start to use several different methods. There's a swallowing technique. I use those because they're really pretty accurate. But there's no one technique that's superior, and you start to develop where their rest position is. And then you just have the patient bite down. Okay, bite down. Measure that. That's the difference. And so you can see on this patient here, it was pretty well appropriate. The classic literature on that is, there's 2, there's Nishwanger and then there's Silverman. And basically, I can't remember which one was which, but basically they said that it's about 3 millimeters. They had it in imperial units, so it's like, 2/32 of an inch or something, but it's 3 millimeters is the difference in the average human as to what that should be. That's why we do that with dentures. That's why we do that with removable, but that's why it's also important to do that with fixed patients, because then you can start to develop, okay, do I need to open this patient's vertical back up? Have they collapsed? Are they right at their occlusal vertical dimension of rest whenever they bite down? Okay, if so, I'm going to have a little bit harder time stretching open. And so that's where your diagnostic planning with your OVD comes in. You look at the labial profile here. That really comes into play whenever you're thinking about doing removable or fixed detachable like hybrids. You don't want to take someone's teeth out and then collapse the lip and then bring it back in and create like a crease. And you also don't want to have somebody who's already edentulous and atrophic, and you don't want to put something fixed in there and leave their lip all the way sunken in, right? So that might be a situation where you want to do, if they want something fixed, which I'll have a little teaser at the end, that might be something like a Marius bridge or a true fixed detachable type bridge situation. And then you look at the facial proportions. So dividing the face up into thirds, usually that's like the orbital rim here to the subnasale to submentale with the lips, and so that's dividing up into thirds. And you want to make sure that those are roughly equal. And then if you subdivide further, the lower half of the face, so subnasale to submentone here, this measurement here, so if you look at the angle of the lips or the commissure of the mouth, then typically speaking, generally, roughly, this is 1/3 here and this is 2/3 here. And so sometimes I don't really use that measurement that often, but that's something that you can look at if there's something that's way off on the portraits, right? So anyway, so you look at the tooth analysis, you look at the positioning of the teeth, and this is whenever, if you start looking at zeniths, that's what I really look at first when I start wondering, like, hey, have these teeth migrated? If there's no obvious aberrancy, then I start looking at zeniths. If you look at zeniths and they're all in different places where they should be, so like say the mandibular teeth on this patient here, that means that those teeth have super erupted over time and the whole tooth has come up as this patient has worn down their teeth. So that's when you know that there's some aberrancy in the positioning of the tooth, and that's when you know you need to either correct it somehow, like with crown lengthening or orthodontics or some type of compromise where you don't do anything but you acknowledge that that's present. Migration happens, so migration as well as dentoalveolar extrusion. You have super eruption of the teeth and crowding, malocclusions. You can have tipping, and then you can have, on the positioning, you can have contour changes that occur because of the dentoalveolar extrusion, right? So your proportions on your teeth are now off because of the wear and because of the change in the position of the teeth. And then looking at proportions, this is from Meunier's article. That's the ultra classic. That's from 2003. That article is called, it's like tooth proportions in worn and unworn dentitions. That's what I refer to a lot for proportions of teeth. That's where they develop like the idea of the golden ratio and the proportions here. And then this is from an orthodontist who's in, I think, Washington, who came up with this chart here that has the average width ratios. There's 3 charts. I just threw this one on here. But basically, if you have this is relative to the maxillary central. And so you can start to develop the widths of your teeth, and you can work backwards and forwards depending on which teeth need to be waxed up. You can start to develop like if my width is 8 millimeters here, you can actually plug in mathematically and generate this patient, if I was to match this central, the width and the length of this central, then the mandibular incisor should be this length or width. And so that's a really handy, tool sometimes if you're kind of working from scratch and you have some issues like with some diastema. But basically, going back to the fixed and the removable, kind of working together in these aesthetic analyses, look for like a 21X, 8.5 by 10, or for the Phaneris B72, right in the middle. Average tooth height, tooth width, 8.5 by 10. 8.5 by 10. That's what you start with, and then you start looking at different other factors that might, determine if you need to go wider or longer, or the proportions need to just be, dragged on the computer to be bigger. And that's very easy to do in the wax-up software. And then you look at, from the dentist perspective, you look at foundations. So you ask yourself, will this tooth support a restoration? And you have to ask yourself, what do I need to do in order to have this tooth support a restoration? So one of my good friends, Dr. Fichera, is here. If you'd raise your hand there. Okay. So Dr. Fichera and I, we did this case about a month or two ago, where this lady came in with very short clinical crowns. She was missing number 8 and number 9. And we established that we needed to double abut the canine and the lateral, canine to lateral, to do a 6-unit FDP. She had failed implants in the past, mega defects. And just looking at the foundation there, number 7, number 10, as soon as I had touched that tooth, and she had a tight bite, with some super eruption of the mandibular teeth, as soon as I had touched that tooth, I would have been into the pulpal chamber, to do my lingual reduction to make space for restorative. So we said right off the bat, we need to do prophylactic endo on these laterals, and that's what we did. Because whenever I prepped down, I could see, so Dr. Fichera comes in and he'll help me with the endo. As soon as I prepped into those teeth, after he finished, I was like, yep, this is where the chamber was. That's where my reduction was. And so you have to look at the foundation of the teeth as well. If you're trying to drastically correct prosthetically the angle of a tooth or the positioning of a tooth, you need to start asking yourself and asking the dentist, hey, are you sure we can pull this off? And if we can prosthetically, do we need to do something else like endodontic therapy in order to not violate biologic principles? So there's a couple of really good books that go along with that. That's Fradiani's Aesthetic Analysis. That's a 2-part book series, and those are phenomenal. If y'all have never heard of Fradiani or read his textbooks for aesthetic analysis and for treatment execution, especially in the second textbook, he does a lot of that, where you have periodontally migrated teeth. He drastically reduces the contours, but has to do endo on a lot of them to make it work. And so that's where I got a lot of the inspiration for looking at that from. And you have to ask yourself, what do I need to do in order to create a foundation for this restoration? Do I need to get rid of all the teeth, and just do removable or something that's fixed on implants? Can I use this tooth? Is this tooth going to make the trip? And what does the foundation look like as a whole? Because what you don't want to do is, you don't want to lose sight, once again, of the forest for the trees. And so you can use, there's objective charts that you can use. This is a classic one that I like to refer to sometimes if I have a question, or if I'm working with somebody else that has a question about a particular tooth or a particular situation. This is Estevez 2011. We start looking at things like ferrule. We start looking at things like the endodontic status of the teeth. Have they been endodontically restored in the past? What's the foundation look like in that respect? And then what does the root length look like? For root length, what I like to usually use is more of mobility. So clinical mobility is where I kind of tell what my prognostic factors are going to be. But the point of this is to show that there's a bunch of different little things that can add up to give you kind of an objective, or at least a less subjective way of determining a prognosis for a particular tooth to use as a foundation. But once again, do not lose sight of the forest for the trees. And then also on the prognostic analysis, you don't want to have these patients come in who, they really want fixed, but their hands look like this because they have osteoarthritis terribly, right? Somebody like that, you have to ask yourself, is this patient really going to be able to get in with a water pick or with a super floss and clean a hybrid restoration, something like this? The answer is no. And so you don't want to have to, in 3, 4, 5 years, come back in and have a conversation with that patient. Hey, this is the situation that I see. They're going to be really upset. And so providing this kind of prognostic analysis of the patient's willingness and the patient's abilities is really important. And for somebody like this, that's when you want to consider, either if they come in like this, you want to consider, hey, Mrs. Jones, like maybe we just think about doing something that you can take out and clean in the sink and just put right back in, versus something that I have to take off after every year or every 6 months because it looks like this, and you know it's going to self-destruct. Right? So prognostic analysis is very important. That is, comes down to their age, their access to care, their future parafunction, which is to say that if somebody comes in without teeth and they want a hybrid or they want a full mouth rehab if they have some teeth left, you have to ask yourself, if I do something, it's not going to be as good as what God gave them in the beginning, right? And so you have to ask yourself, is this going to last? Is this going to break? And what am I going to do if and when it breaks? What am I going to do in order to fix this or ameliorate this situation if and when it breaks because of future parafunction? And then, how many compromises do you have to make during treatment? Because like I said, if you have a treatment that goes off without a hitch and that's in a complicated situation like this, you tell the patient, let's go buy lotto tickets together. So the finances come into play. What can the patient afford, realistically speaking, or what can they stretch for? The appointment availability. If they're working 8 to 5, they can't take days off, and they have 5 kids and this, that, and the other. You have to sit down and tell them, hey, this is how many appointments, this is how long it's going to take, this is how long it's going to be at the laboratory phase. Are you still okay with that? Yes or no? Most people are okay with that if you explain it to them ahead of time how long it's going to take, rather than dragging stuff out and they have no clue, that it's going to take a year. So that's why I like to call appointment fatigue. People that come in, you think that you're like a hot shot and you think that you're doing this great work, and this patient's just like, yeah, man, I'm tired of going to the dentist, right? So you have to kind of work that into your equations on how long these treatments are going to take and if the patient can tolerate that. All right, so enough about planning. That's just to give you guys an idea. And, that's what goes through my mind whenever somebody comes into my clinic and I start to analyze them and start to work them up. And that's something, just to put it into perspective, that I think that you guys are going to have, we, as dental technicians, there's a lot of input that goes into that a lot of people don't really appreciate. And there's a lot of the tooth analysis, the foundation analysis, the aesthetic workup that goes into that wax up that you guys don't see the patient there in the clinic, but it's there and it's really important. And the prognostic factors, sometimes you guys are in a really good position to start to nudge the dentist like, hey, this might be something that we want to think about doing, because can this patient clean this restoration? No? Okay, then maybe we should do like an overdenture versus a hybrid, right? So those are conversations that I think are really good to screen on the technician perspective and the technician end, and that's why I bring it up here, because you guys are really good at those conversations. So anyway, let's go through and talk about preparations. So getting into actual treatment and working up and going through the workflows. And so what I do on my diagnostic wax-ups, I take trio scans. I take the photographs that I showed you, the smile, the repose. From the repose, I start to work up where my 8 and 9 position need to be. And from the smile, I start to work on where the smile arc needs to be. What do the gingival aesthetics look like? Where's the positioning of the teeth? All that good stuff. And basically what I do is, for a full mouth or a single arch rehab, I will do the diagnostic impressions articulated at MIP or centric relation. If their MIP is really good and very close and they have a stable bite, I will usually open them up at the MIP position and I'll take a trio scan at the MIP. If they have an unstable bite, or if I know I'm looking and I'm doing like a quick manipulation of the jaw, what I usually tell people to do is, hey, put your tongue on the roof of your mouth, open, and then close with the tongue at the roof of your mouth. That's a very natural way to get somebody to go to CR. And you don't have to sit there and, pal around on their jaw or get behind them and try to jam their jaw up into their condyles. That's a quick and dirty. If they do that for me and it's way off, then I'll start to work on, doing a CR record and actually mounting that digitally with like a leaf gauge. And so you get your occlusal registration, you wax up your 8 and 9 to ideal, and then you wax up the rest of the maxilla to ideal. You don't even look at the mandibular arch at all at this point. And then you wax up your mandible to ideal, and then you open the vertical until the proper contacts are arranged. And so what that does is when you do that on the computer or on your on the articulated casts, you're going to have something that basically doesn't come together quite right. Okay, and then what you do is you start to do like a diagnostic preparation on your wax or on the computer, and you tweak things until everything comes together correctly. And that is your proposed or your initial new occlusal vertical dimension. What does that look like? So we idealize the anterior teeth here. We idealize the mandibular teeth there. I basically, in the computer software or at the lab bench, you don't look at the other arch. You wax up to ideal, and then you put the two halves together to the whole, and then start to articulate it and get it dialed in. And so what you do there is you're idealizing both situations, and you're not using the other one as a cheat. Well, I don't know about this contour here. You're starting at ideal, and then you're working your way back. And so then what you do is you just tweak as needed, and then you can ghost these on Exocad. Show of hands, people that use Exocad and 3Shape. Okay, you can do this on both software systems, but what I do is I will ghost out the anatomic wax up that I perform here. I'll ghost that out, and then that becomes my new occlusal vertical dimension. So I can actually measure on the computer, hey, how far did I open up at the molar? How far did I open up at the premolar? How far did I open up at the incisal edge? How much did I open up at the pin? Typically speaking, this is going to be around like 3 millimeters or so. If I'm opening up, there's what's called the rule of thirds. So if you open up the pin 3 millimeters, that's typically going to equate to like a 1 millimeter open at the molar. And so that when you talk about restorative space and how much you need to prep, that becomes key in your diagnostic wax up here. So we've opened up about 1.3 millimeters at the molar. That's fine. Tweak as needed. And so here's an example here. So this gentleman came to see me. I was the fourth opinion on this guy. He was referred to me. He went to Clear Choice. He already had dentures made. They told him, hey, you need all your teeth out. Your teeth need to come out, and you need to have double arch hybrid. And so he went for a second opinion, and the general dentist said, go see an oral surgeon that we use. The oral surgeon basically said, yeah, double arch hybrid. So the general dentist sent the patient to see me. I said, look, man, I wouldn't do that, because the foundation was correct. His teeth underneath the hood, so to speak, were perfect. So he had good roots left to work with, and the actual endodontic status of his teeth was fine. So what I did was I started with my aesthetic analysis. I said, man, this guy at repose, he's like negative 5 millimeters at repose. I said, I can bring down that incisal edge 4 to 5 millimeters and still be perfect. So I can add however much he's lost. I can add 4 to 5 millimeters there, and I can still have an acceptable tooth height and position using the repose. And then what I did was I looked at I said, okay, if I do that, then these teeth are kind of short. And so the 8 and 9 is kind of short. And so I know that he's worn those teeth down and that they've supra-erupted as he's worn them, looking at the zenith positions. And so then what I did was I said, okay, I can go south, which is you hear the term going north and south. I can go south by adding incisal edge to the initial situation, but then I also need to go north as well to get up to that 10 millimeter length that I'm looking for the 21X, right? So what I sent this patient for was for crown lengthening in order to expose functional crown lengthening and aesthetic crown lengthening in order to expose more of the tooth there. And so that's how I got up to a proper contour, and I'll show more pictures on this patient here in just a minute. But that just reinforces the fact that looking at the photographs, looking at the zenith positions, looking at the foundation as a whole plays a huge role in doing a diagnostic wax-up and a workup for these cases. And so to affect that in the clinical situation, sometimes you have people that, I don't know if I want to go through with treatment. But you just you do your diagnostic wax up on the computer, you print it. Doesn't take very much time, doesn't take very much in the way of resources to print these. You make a polyethylene splint on these, so you can't use BioAcryl or an acrylic type splint, because if you do this in the mouth, it's going to lock in, right? If you put acrylic on it, so you have to use something like a copyplast, something that's not going to stick, or you can just use a VPS putty. So you make a matrix, you try it in the mouth, you put copious amounts of Vaseline on the lips, and then you put some Bisacryl temporary material and say, hey, what do you think? Patient starts crying, because this is so much different than what they're used to seeing in the mirror every day. Somebody who's very conscious and not to say the word vain, but they really care about their teeth, and that really hurts their self-esteem. They see something like this, they're on board for treatment. And so this is a really powerful tool to use. The first step you do before you do any preparations, you look at the mock-up and you see, where are my contours looking like? You assess the incisal, the edge position relative to in repose. You look at it as compared to the smile arc here. You can print a mock-up as well in like a temporary crown and bridge material and just go right on to the teeth there. If you don't want to print the wax up and go through the steps of doing this, you can just print the mock-up. I've done that before. And, that's a highly motivating factor. So a question about testing OVD with a splint, and I won't spend too much time on this, but just suffice it to say that this is outdated literature from the 70s. So what they did was they would test, this was back in the day when you did bilateral balance on natural teeth, which obviously we don't do anymore if we can help it. But these two articles, basically what they did was they took healthy individuals and they opened vertical 3-4 millimeters with bilaterally cemented temporary splints on one arch and gave the patient bilateral balance on their posterior teeth. And then they looked at symptoms. Of course, people had symptoms. They didn't have any sort of anterior rise. They didn't have the proper guidance, and they had symptoms. But what's weird is, if you look at the Helsing and the Carlson articles, which this research was based off of, that's why we do splints. They say, hey, you need to test the opening of the vertical and see if the symptoms come, and then they go away. So when I looked at the classic literature, I found that, and that's like a very small point there, that bilateral balance. But of course that's going to happen. And they even found, though, that when you do that, those TMJ symptoms do go away over the course of like a week or two, even if they have bilateral balance. So for that reason, I typically do not do monitored splint therapy as a precursor to a full mouth rehab, because if I've gone through and looked at my OVD analysis and I know that I'm in the ballpark, then there's not going to be an issue. But what you can do is you can do a printed or a milled mock-up, like I said before, that the patient just wears as a splint, as kind of like a functioning splint, and then they just test that out for a couple of weeks before you start to do your diagnostic preparations. And then you can produce a splint easily if you wish. So going back to the ghosted image of the wax-up, right, with the new proposed vertical dimension, you can make a splint on that and save that as your new vertical, and then make a splint on that with the opening there. So it's pretty easy to do. So preparation guidelines. I'm going to talk about the material selection here, and before you even start touching the tooth, you kind of need to know, hey, what am I going to restore this with? Because that makes a huge difference in the way that you approach the preparation and the way that you approach your impressions, the way that you approach basically everything in the laboratory is understanding the material of choice. And so I want to go over some things with y'all, particularly about zirconia, because that's pretty well all I use in the mouth is zirconia. And so there's a couple of things But this applies to everything. You need to understand the material. You need to understand the way it works, the way you have to prepare it, the material thicknesses, the axial reductions, all that good stuff in order to make it work. So PFM versus all ceramic crowns, lithium disilicate versus zirconia. You need to understand how these things work, retention resistance form, and how to use different types of zirconias, because a zirconia is not a zirconia is not a zirconia. There's 3 mole, there's 5 mole, there's 4 mole. There's my favorite, Zircad Prime, a plug for Zircad Prime, a blend of 3 to 4 to 5 mole in the same puck. And so there's a lot of different factors that go into your preparations based on your material selection. And so for occlusal thickness, this is some good literature here. Two articles where they looked at occlusal thickness versus in fracture resistance for monolithic 3Y mole zirconia. No difference in fracture resistance, 0.5 millimeters to 2 millimeters of occlusal thickness, which tells you that it's almost like gold, right? It's not going to break. And you can get it down pretty thin. That's why, if you see some of those classic, those older preparation guidelines from, the big labs, right? Like they say, 0.6 millimeters, do a gold reduction there, and you'll be fine. And then, so the reduction that you have to have on zirconia, as long as you're using a 3 mole, which is a little bit stronger, doesn't have to be as crazy as, say, like for Emax or lithium disilicate. Axial reduction, this is a really neat article here. They looked at axial reduction, different preparation designs versus the fracture load and fracture resistance of 3Y zirconia. And what they found was basically all of the preparation types that you can throw at this material, they're all going to work under physiologic loads. It just depends on what you're looking for and what kind of preparation that you want to do. They found that the 1 millimeter axial reduction was the best for strength for zirconia, and basically the shoulder had the highest resistance to fracture there. But what I typically will do is I'm a minimalist when it comes to burrs and the burrs that I use for my preps. And so I basically just have a round-ended tapered burr that has the nice rounded point on the end. I order ones that are about 1.8 millimeters thick, which is kind of thick, but 1.8 millimeters thick at the tip. And then I just run that halfway through the tooth. That gets me about a 0.9 axial reduction. And by the time you're done like roughening things up and smoothing things up and getting your finish lines the way that you want them, you're going to be at 1 millimeter. So that's why I use a 1.8 millimeter burr in order to affect that. And I end up usually with something that resembles more of like a deep chamfer, which is perfect. And then this is the other ultra classic article on connectors. So with zirconia, you have to understand the material that you're using, the connector thicknesses. Back in the day when zirconia first came out, like Inceram and all that good stuff, and the original like lava, what you would do is you would do like a fully reduced connector, do a little circular connector, 3x3, like you were doing for metal ceramic, right? But those had a propensity to break. So this is from 2007. This is 14 years ago. But they looked at 3Y zirconia, and they found that depending on the units, right? So 3, 4, and 5 units, they spit out due to this cyclic fatigue loading. They spit out recommendations for connector thickness here. And so if you can affect these, then you're going to be in good shape. Now what I typically do is I'll go for a full monolithic zirconia. So I'm looking for the default setting on my Exocad for the connector thickness is 9 millimeters squared. If I have a 4 or 5 unit bridge, I'm going to obviously bump that up, manually, but just the default setting usually for 3 units is perfect. A little bit more if you're going to do a 5 mole zirconia or you're going to do like a blend, but the principle is still the same. Now on preparation guidelines, prep height and total occlusal convergence, there's a couple things just to go over here. When you're prepping a tooth in the mouth, it's not like prepping on a typodont. You can't just look at it on the tabletop and just go in with a burr. You have to manage the patient. You have to manage the lighting. You have to manage the indirect vision. You have to manage the saliva. You have to manage patient comfort. You have to manage the positioning of the patient, supine, semi-supine, which way they're turned. It's really tough. So Goodacre, who was the dean of the dental school I went to my first year, and then he retired, he's the big name in like the godfather of modern prosthodontics. And this article from 2004 was really good, and it talked about, hey, what do you want your occlusal gingival preparation height to be for maximum predictability? And how does that relate to the total occlusal convergence, aka your taper? And so what they looked at was, they said, if you have a TOC of around 16 degrees, you're going to be fine. And so that's actually, if you look at 16 degrees on like a piece of paper, if you trace it out, they say in the textbook, Schillenberg, hey, go for 5 to 6. But if you get 16, that's a little bit tapered there. So 3 millimeters is fine. This is for conventional cementation, zinc phosphate, RMGI cements. With the newer resin cements, you can have much more preps or much more TOC and shorter preparation heights and still make it predictable, and I'll talk about that at the end. And so it's more important to have resistance form. So resistance versus retention form. Retention form is like, hey, I'm biting on a piece of caramel. My crown's going to come straight up and out of my mouth. That's retention form. Resistance form is more important. That's resisting off-axial loads in order to keep the crown on, to keep it from rocking. So for that, if you have a patient or a dentist who's sending you cases and they're saying the crown came off, redo crown, you get this little tiny preparation there, ask them, hey, can you put a couple of grooves in? If you put mesial distal grooves in, that's going to drastically increase your resistance form and keep that crown from coming off due to buccal and lingual, off-axial loading. So that's important to do as well for preparations. So what I do is I'll have a patient come in, I've got the wax up ready to go, and I'll do the mock-up in the mouth at the preparation appointment after I've anesthetized. And you can do two things. This particular workflow and situation, I decided just to do one arch first and then come back in later and do the second arch. So I just did the maxilla for this patient. You can either test the articulation with the mock-up in place, but that's optional because what I'll do is I'll do that in the provisionals. And then once you get your bisacryl in here and load it up and take this stent off, this copyplast stent off, then what you're left with is an idealized setup. And now all you have to do on my end as the dentist, you can do this almost blind. You go in there and you treat it like a typodont. You start doing your occlusal reductions, 1 millimeter, 1 millimeter, 1 millimeter, 1 millimeter. You do your axial reduction, 1 millimeter, 1 millimeter, 1 millimeter, all the way around every tooth. And then basically what you're left with is your reductions that are tailored to that specific wax up. And now, once you've done that, it's a little bit rough at first because you have your axial reductions, and you have your occlusal reductions, and you have your facial reductions and such. Now what you need to do is just connect the dots. So you go back in, you pop off whatever bisacryl is left after you've done all of your reductions, and then you just make sure that your finish lines are smooth, and you're done with your preparation at that point. So what you have left with is your preps, and you need to start asking yourself, like, okay, where am I at? What do I need to do at this point? And I'll tell y'all, at the preparation appointment, I get tired. This is what I look like at the end of a preparation appointment. My preparation appointments are 4 to 5 hours, and I'm dead tired because a lot of brain power goes into making this happen. But what I don't like to do is I don't like to do 8-hour all-day appointments because by the end of that 8 hours, that patient is sick and tired of being in your chair. We can work all day in the lab, right, like on, doing a wax up or something, but the patient's not there. The patient's in your chair, they've been numb, they're coming down off the anesthetic, you have to re-anesthetize them because their teeth are now sensitive. what I do is I break this up into 2 4-hour appointments, 4 to 5 hour appointments, and I'll see the patient like on a Monday, and then I'll see them on like a Tuesday or a Wednesday. Give them a day to like recoup. So see them like on a Wednesday, and then you prep the other arch. They leave with provisionals, obviously, on the maxilla. I'll usually prep the maxilla first. That's just personal preference and what I've done, since I started doing this. And you get the, you don't even check the bite. You say, hey, like, just eat soft foods. Don't even worry about the bite till we prep the mandibular arch. They're going to be fine. One day it's going to be fine. So when I do my impressions at the time of the preparation appointment, I don't even take a bite record. And I'm going to show, this is going to be one of the cruxes of the things that I want to share with y'all primarily today. I don't take a bite record. I use a diode laser, which is really good for cleaning up and doing gingival troughing, especially if you're taking off old crowns or you're prepping class 2s. If you have a dentist if you have a practitioner who has, let's just say, poor gingival control, recommend a diode laser. They're cheap. They're effective. They're fast. You can use them on the fly. It doesn't take a lot of effort to get this, and you can get these really nice gingival troughs that will heal nicely. We use them in like periodontal, sometimes in like doing the low light level, biomodulation for periodontal, pathogens. But it really improves your impressions if you're doing with the diode laser, especially if you have to get a final impression like that day. This is the way to do it and not worry about bleeding and hemostasis. And so I don't take a bite record, and what I do is I superimpose, and I'll show this here visually a couple minutes, I superimpose this cast, this impressions cast that I've generated with the scanner on my wax up STL at the proposed vertical. That's my bite record at the impressions appointment. And so the bite record that I use for the provisionals is based upon my wax up that I've spent all the time working on. So this is the one that I use. This is from CAO Group. It's called Precise ATM. This is a really nice diode laser to use. The reason why I recommend this one is because it comes with a spool of like basically fishing line. It's a fiber optic cable. You don't have to buy these like $5 tips for it. You just like cinch off a little piece, cut the tip off, and you've basically got like a 10-year supply of spooled fiber optic cable to use as tips. So this machine works really well, and it's not like electrosurgery. You don't have to have electrodes and worry about if you're going to fry the patient's pacemaker. So this is the superimposition. This is really important. If you use Exocad or if you use 3Shape, you can do this, and it's very easy. So you take your impression scan, and then you take your derived wax-up bite that you've saved as an STL file at the open vertical. This just happens to be for this patient. I tried it this way. I opened up the vertical and then left the original pre-op situation here, and then saved that as an STL file at the open vertical. And then I brought that in at the preps appointment, did my superimposition on non-anatomic, basically like a non-anatomic land area, aka the gingiva, right? The software is powerful enough to use, you're not doing like major periodontal recontouring right at this appointment. And so the software is powerful enough to do this. So anywhere you see blue, it's going to superimpose, and blue means like this is a perfect spot-on match. You can even see in this superimposition where I didn't have to prep this guy's teeth on the incisal dimension, right? So here, when I opened him up, you're not going to prep. You're opening up, you're making that prosthetic space with your open vertical. That's the reason why you open vertical. I opened up the spacing here for this patient for prosthetic space, and you can even see when it superimposes on the pre-op situation how it does that, and it has a match based on that. So that's how I will do my bite articulations. And then what I do is I do a quick and dirty margin line detection on every tooth, and then I design provisionals based on my wax up or based on the pre-op situation. And then what I'll do is I'll print these. So the way that I print these is in 4 segments. So you have a posterior segment, and then you have 2 on each side, and then you have 2 anterior segments. This is just for path of draw. So if you look at the draw on the anterior teeth, if you're prepping all of them, unless you really over taper the teeth, you're not going to have draw. That's why I don't like doing eggshell temporaries. If y'all have ever seen or done eggshell temporaries, that's why I don't like those, because when you put it in, it's going to be hard to get it out if you do one segment. So that's why I do 2 segments here and split it at the midline. And then I'll do 2 on either side on the posterior. So it takes me, a couple hours to prep, 30, 40 minutes to do my impressions. And then I go back to the laboratory, spend about 30 minutes doing the design of the temporaries. And then it takes about 45 minutes to print these. So I'll actually print the temporaries using a PMMA. It's from Dentka. It's a crown and bridge material. I'll print the temporaries, and then the patient goes home with these. These are made exactly, the contours are where I want them. The occlusion, what I'll do is I'll do a little bit of adjusting at this appointment, but the occlusion is usually pretty spot on. And then the patient goes home with full contour temporaries that I don't have to reline or fiddle with, right? So I can just sit back there in my laboratory and have a coffee while I'm designing these and take a break. And then take a break for 45 minutes, patient takes a nap in the chair, it's perfect. On the provisionals, so talking about provisionalization, there's many different ways to do it. There's as many ways to do it as there are materials. You can do printed PMMA. These are for hybrids. You can do it that way. You can do with there's a new resin from Bigo that's come out that is it's a very strong resin that it's impregnated with either glass ceramic or zirconia. What is you know what it's impregnated with? It's from Bigo. Okay, but it has some sort of a glass in it that you can actually print final restorations. I wouldn't use that for a final restoration, obviously, but I would definitely use it for temporaries. So you can print your temporaries. You can do milled PMMA temporaries, so you can have the patient go home with something printed and then have them come back. If it's going to be 3 or 4 months, like this patient was for a single implant that needed to heal, you can have them come back in a couple weeks later and have a milled PMMA ready to go. Or you can do what I like to do in some situations, because of the expense being so low, because I outsource the milling, I'll actually have a zirconia, multi-layered zirconia crown milled out, and I'll use that as a temporary in some situations. So like for this case here, this is for a single tooth implant. All I did was I went in and polished it, put it on the tie base, goes in the mouth. So in these situations like this, I'll do a zirconia temporary. You can still air braid that and bond some like composite to it if you need to open up the emergence profile, but that's what I like to do if I know that this is going to be in the mouth for a good amount of time. And so for the techniques, like I said, I like to print in 4 sections, and that really helps too if you're at the lab, and you get this impression, hey, this patient's coming back in like 2 days. Can you get me something fast? Yes, I can. Or what you can do is you can prototype your provisionals with like a crown and bridge like a model resin, right? Put those on your casts, and then you can do like a putty, or you can do a traditional workflow where you create like a auto mixed PMMA in the laboratory and then trim it from there. So there's a lot of different ways to kind of play with this and fast prototype these things in order to increase your efficiency. So the next thing I do is the patient returns about a week later, and they've had time. When you prep somebody for 4 hours, and their mouth is open and they've been numb, they have no clue where their bite is. They're going to be biting like this. Yeah, this is my normal bite, doctor. And their face is sagging because they're numb. So what I do is I'll generally have the patient come back about a week later. Anesthetics all worn off, obviously, hopefully. And then I'll do an equilibration. And I'll talk to the patient, what do you think about the looks? What do you think about the way everything feels? Have you had any issues endodontically? Where are we at? Hey, doctor, can you, smooth this down? I'd like for my 4 front teeth to be a little bit more square. Sure, no problem. You buzz those down a little bit. That was what this patient requested. And then, so you're checking off your boxes. Does the aesthetic parameters work? Do the functional parameters work? Does my occlusion look good? And does the foundation look good? And then once you do that, then you bring in and you do a new occlusal record at that appointment. And so what you do is you take an impression of the provisionals, and then you take a bite record on the Trio scanner with that patient at that final vertical. Okay, because you have your initial vertical that was proposed in your wax up, and now what the patient actually presents with is going to be your final vertical dimension. And so what you can do then in the software, going back one slide, you can start to superimpose, just like I did before. You can superimpose your provisionals with your preps, with your new bite record, and you can have a very accurate digitally cross-mounted final articulation. And so that's exactly what I do in these situations here. And it's really easy to do with the merging on the CAD software. And the reason why I do that, and I don't take bite records with VPS or with like a putty or with an acrylic, is because the best articulator is the patient. And so when they come in, we get the new occlusal record. We superimpose everything. You need photographs, if you want to make tweaks in the laboratory phase when you're ready for your final restorations. But you make some tweaks, and then you can do your digital superimposition using non-anatomic or non-tooth anatomic land areas here. So like up in here, the software is very precise and very powerful. That's your final bite record there. And then you can start fabricating your final restorations, making tweaks as you want. And then that's ready to be milled in your final material. That's very easy to do in Exocad. It's very easy to do in 3Shape. And all you really need from that patient too, if you're doing this without doing a Trio scan of the bite record, with its own scan, what you can do is just ask the dentist, hey, can you send me an upper and a lower provisionals cast with the preps? Most will do that anyway, right? Because they want to go by for you to follow. And so you scan everything in, and then you just superimpose your preps casts onto the casts of the provisionals. This also works for hybrids. I'm just going to show this one slide here because I don't have time. That would be another lecture, but this also works for doing full mouth on implants. And so you can see that here on this particular situation here. So what I usually do is by the time we're ready to go for the final restoration, the only thing I have generated analog for a patient like this is a final impression. So, and I'm starting to get away from that more. I'm starting to experiment with doing these impressions in the mouth, and there's a particular workflow to make that work. But basically, you get a final impression, and then everything else flows from that digitally. And then you can end up something like this. So I'm going to take a side trip real quick on photography. So in the laboratory and in the clinic, we should all be taking photographs. If you want to promote your brand or if you want to promote your work, and trust me, I know how much work goes into doing what we do. You need to take photographs and show people. That way people can understand, hey, this is what I do and this is how much time and effort I spend on this. So what I like to do is I've tried everything photographically under the sun. There's 3 main camera types that you can find now. DSLR, so Nikon or Canon. Mirrorless, which would be like a Sony. And then you can use a smartphone. And then, but I'll tell you all this, the more important thing than the actual camera is the flash. So people think, hey, what camera do you have? What you really should be asking is what type of flash do you use? Because the flash type really determines how well or what the quality of your photographs are going to be. So these are just some examples on the same patient with using different flashes on a DSLR. Ring flash, traditional, you're going to get like this little halo here on the teeth. It's good for showing texture. With the dual point flashes, so that's the ones that come off the side, and point in, those just by themselves are going to give you some harsher light, but they're going to give you nicer, you can see a little bit more of like, it just has a nicer like curb appeal to the photograph. It's hard to quantify this. And then when you go to like a dual point with a bouncer or a strobe light that's really high powered, but has a big diffuser on it. So you think like, when you go to the photography studio, they have those big diffusing boxes of light. That's when you're really going to get this nice soft light here on the teeth. That's when you start to get like those textbook quality photos. And then if you go to way down the rabbit hole, what you can use is something that's continuous light. And that's when you have to have a really high intensity of light in order to make this work. But these photos actually show probably the most texture and the most color on them, and they don't have that harsh, they don't hit the teeth harsh with the flashlight. So I really like to use continuous light. And what I've gotten really into is using the smartphone. So I have an iPhone 12. You can use this with the 11 and use it on the 2x zoom factor, but I use this really cool thing from Photomed that's called an SDL, smartphone dental light, and it's like $500, and it's a continuous light. And what you can do, so you can see real time on the camera, what your picture is going to look like, and then also what you can do is you can use this for polarized photography as well. You can also take videos like surgery videos, and you can put it on a tripod and show yourself working in the laboratory. But it's not the best for portraits. It's the only downside. So if you have something like this, and this is what polarized photography can offer you. So if you have something like this where you really want to determine objectively, hey, what does the shade look like on this? What do the translucencies look like on this tooth? It's hard to do that with regular lighting, with a flash or with a continuous light. So if you put a polarizer on, that takes away all of the glare. And it's like if you ever go fishing and you have polarized sunglasses on, you take them off and the surface of the water is really shiny, right? But then when you put your polarized sunglasses on, all of a sudden you can now see like a couple inches to, you can see the fish swimming around now, because all of that glare from the sun that's bouncing off and hitting your eyes is now polarized out. So the polarizer is really good for shade matching and also for like chroma and translucent effects as well. So, and it's inexpensive. I say that because who doesn't have a phone, right? Who doesn't have a smartphone that can take pictures just like that? I have mine set up to where it basically sends to my Google Cloud Stream whenever I take a photo on my phone. That way I can pull it up on the computer within like 3 minutes. The other thing I'll use for portraits, there's two different ways that are to take really nice portraits. This is the strobe kit here. This is from Newer. It's the same company that makes this LED light. So I bought the LED light here to work with the smartphone. And so what you can do is you can come in and you can do portraits with something like this, or you can just use your regular strobes with like a DSLR. So back to the full mouth rehab. And I'm going to go quickly on this. You did your digital cross mounting, and so you have your articulation set. And then I don't use a face-bow because what I have is I have my aesthetic references captured in my photographs. And then for the terminal hinge axis position, as I said, the patient is the best articulator. And so if you go in and you have if you have your articulator like this, you can measure this to the nth degree. This is from the late 50s, I think, Weinberg. And this is math that I can't even read this because it's so complicated. But this guy was looking at basically condylar angles and face bows and centric relation records. And they basically said, if you're within 2 to 3 millimeters, it's going to be negligible at the teeth. So that's why I'll use an anatomic average on my mounting for the terminal hinge axis position. And if you use your final articulated centric relation or centric occlusion position that the patient gives you in the mouth, when you take that bite scan, you're going to be dead on whenever you go for your seating appointment. So what I like to use is material on natural teeth and on implants. I'll use Zircad Prime almost exclusively. And the reason why I like that is because basically the built-in gradient is it's really nice. And I'll usually only do a glaze and stain on the facial surface only. This is important too when you talk about fit and your insertion time, because what I'll do is I'll do a glaze on the lingual and the occlusal and the proximal surfaces. I'll do a polish only, and then I'll do my glaze on the facial. Now what that does is several things. One, you've worked so hard on the software to make these proximal contacts perfect. On Exocad, I use a 0 proximal contact, and I make them pinpoint, right? So 0 contact on the proximal surfaces. You've worked hard on that already, and so the way it comes out of the mill, centered, is perfect. And then when you start adding like a glaze layer on your proximal surfaces, now you're increasing the surface thickness there. You're going to have issues with the fit. And so that's why I like to polish the proximal surfaces only. And then the facial surface, obviously, I tell people that belongs to the patient. The facial surface, the aesthetic surface of the restoration belongs to the patient. So that's where I'll do like a nice glaze and stain. But typically with Zircad Prime, all I'm doing is like a glaze because it looks that good right out of the box. And so I'll skip this because I have just a couple of things I want to show y'all and I'm running out of time. But on my implant restorations, there's a bunch of different ways to do them. And what I typically default to for an anterior or posterior that I have a good angulation, I'll do a screw-mentable restoration. And so the screw-mentable restoration is with a custom abutment that you can either cement in the laboratory or you can cement it after you try it in the mouth. And so what this does is it really helps with retention and resistance form. We talk about tie bases, right? These little tiny tie bases. And we talked about that Goodacre article, where you have to have a certain thickness or height and width and TOC. And you talk about like a little tiny tie base trying to get this huge molar to fit on that and to stay, very difficult. So if you run into issues with that, what you can do is you can do a screw-mentable restoration like this, where you have a hole in it's hard to see, but there's a hole in the top of this crown. So after you cement this on the custom abutment, then you have that much higher surface area for retention and resistance form, and then you can go back in and do, you have an access hole here where you can go through and it's retrievable. This doesn't work if you have a weird angulated implant, because if you have an axis of insertion of the implant, and you have an axis of insertion of the restoration that's dependent on the proximal surfaces. So this only works in situations where you have a favorable angulation of your implant. And then on this, you can put your finish line way further subgingivally if you like. For special situations like this, if I have a cantilevered bridge, I'll usually do, the only thing I'll say about that is that I'll usually do an analog impression instead of a digital impression in the mouth. And what I've started doing is I'll try in the custom abutment on this is like for a cantilever, I'll try on the custom abutment in the mouth and then make a prep scan of that and then make a restoration based on that. So it's a two-step process. So that's my special circumstance there. But the insertion appointment, usually whenever you do the workflow like this, it basically is just, it goes to nothing. And it's basically on autopilot because whenever you've worked out everything before in the laboratory and you've worked out all of your proximal surfaces and your occlusion like this, all you basically have to do is take temporaries off, clean up, and then start cementing. You have to check everything, obviously. But this was a situation with a patient who we only did a front, upper, and lower rehab on because his implants in the back were still healing. But basically, this patient here, and this is called Fit Checker. This is really good to use. But basically, this patient here, this was my handpiece after I finished the procedure. I didn't use a handpiece at all, that appointment. It was still wrapped up. Didn't use a burr block at all, that appointment. It was still wrapped up in the CSR tape because that's how smoothly this insertion went using the principles that I outlined before. And then if you have issues with retention and resistance form, what you can do is you can always come in and go for some Ivoclean, and then you can always use Monobond Plus in order to use with a self-adhesive cement. If you have issues with retention and resistance form on your restoration, I always use a self-adhesive cement for that. And so this is showing that first case there. If you want to, when you print your casts, you can have these little balls here or these little support pins. That way, if you want to articulate it, you can. And this is just with a facial glaze. And then you want to go for a splint afterwards. And I'll usually use Keystone Soft as my splint material of choice because it has a little bit of flex to it. It takes a little bit longer to print these, but it works really nicely. Two more examples here. So first, this patient here, the thing I wanted to say, this was using that workflow here. The thing I wanted to say, I polished the Zircad Prime only on the facial, and I probably should have glazed this. So this was my first foray into using the Zircad Prime for a full mouth rehab situation, and I would have liked to have glazed it. So glaze it, don't just polish these. So you need to hit it with a little bit of glaze because it has kind of that opalescent pearl look to it when you do that, and it's not as natural, honestly, on the facial surfaces as if you do a glaze. So be sure to glaze these on the facial. And then this situation here, this is the gentleman that went to Clear Choice, and they already had the dentures made for him and his surgery date scheduled. So this was after crown lengthening here. And these were the printed provisionals here. And then this was the final result here. So the retention and resistance was a little bit tricky on those laterals. So that's why, once again, using a self-adhesive cement with a silane agent did the trick here. And last case here. Single arch rehab, natural teeth, worn down all the way. Crown lengthening with a vacuform guide here for the periodontist. And on the axial reductions, have to be honest, cheat a little bit more on the thin side. 0.6 to 0.8 for anterior teeth, it's fine. For mandibular anteriors, I wanted the strength of those teeth to hold up. So I did about a 0.6 to a 0.8. Did my superimposed wax up for my provisionals. Zircad B1, it was perfect. So that's what I have for my full mouth rehabs, and I think I've pretty much run out of time. I have 5 minutes? Okay, I want to show one thing for removable that I've started doing that's really fun, and then we'll take a couple of questions if desired. So I had, and this might be for next time, but I have kind of the first half of this is basic principles for complete dentures, going through the 5 traditional appointments. When I'm doing complete dentures, I do 5 traditional appointments. When I'm doing the lab work, I can have the patient come back to back until we get to the tooth setup appointment. I'll usually give myself like a week and a half just to catch a breather, and then about 2 weeks to process. So that's my workflow with complete dentures. One thing here to note, I always take a bite record at the try-in because that's going to get you a really, like I did for the full mouth rehabs with the provisionals, that's going to get you a very accurate mounting rather than like a piece of wax, you know, that's one solid puck. This will get you a very accurate mounting here for right before you process. And then I'll use the IVA base for most cases. And then sometimes for my overdentures, I'll do traditional heat-packed acrylic, just because sometimes if these are really thin to the cast, I don't want them to move around whenever I'm processing, right? So sometimes when you're shooting acrylic, it'll move a little bit. And when you heat pack it, it's just going in one direction. That's towards the cast, right? So I'll use heat pack conventional sometimes there for overdentures. And then just so y'all, you know, trust me when I say I actually do all of the lab procedures myself. You know, this is me. I'll hit it with the polish, and I learned a really great polishing workflow from Jason actually, which is where, you know, he uses like 10 more things than I do, but I basically boiled it down, you know, to using the Scotch-Brite wheels for I'll use the Scotch-Brite for gross reductions. I'll use the pumice substitute like the Dazzle for my gross polishing, and then I'll use Tripoli and High Shine for a nice high luster there, and that works really well. So these are a couple of the cases that I've done with denture teeth and with removable prosthodontics. And that might be my cue. So, I really spend time, and the point of me showing this is that all of those principles that you learn from removable prosthodontics and being a removable technician, they all transfer back to fixed, because the foundation is different, yes, but the aesthetics that you're looking for are going to be the same. So for last thing, and then we'll take questions, is I want to show y'all really quick about printed dentures. So printed dentures, the 30-second spiel here, the strength on printed dentures is not there. This is printed, and this is IVA-base, CAD. It's not quite there. The fracture toughness and the bond strength of the teeth to printed denture bases is also not quite there yet. So for example, if you look at this chart here, after 12 months of aging, the bond strength of your 3D printed denture teeth is about a fifth to a sixth of what it would be if you just used conventional materials. So I don't think that they're quite there yet, but what I do for printed dentures is immediates. So on immediate dentures, I will do a printed denture workflow. I'll take the intraoral scans. And then what I do, and this is the reason why I do this is because you can get something turned around within a day, or less. So what I do is I process, I print out a monoblock, and I print out the teeth, and then I'll process, or I'll invest with some putty, I'll invest the monoblock, right, with my my denture flasks, and then I'll take, once you're done with that, there's no boil out, because this is just plastic. So you just lubricate everything up, do your second flask half there, pour up, and then whenever you're done with that, you do the half flask with your monoblock. So this is the monoblock is here. So you have your monoblock done here, and you invest this, and then you take that out of your flask, and you pop in the denture teeth, because it's exactly the same. Those denture teeth are exactly the same as what your monoblock looks like here. It's cut off of the tissue about 0.5 millimeter to 1 millimeter, and then you can process with whatever you want. You can do heat process, you can do auto polymerized, you can do IVA-based, you can do whatever you want. And that gets you a really nice, high strength, immediate denture with printed teeth. So you digitally design the teeth, you print the teeth out using like a denture base resin, and then you have your conventionally processed high strength resin for the denture base itself. That you can use for like hybrids, you can use it for immediates, you can use it for your conversion appliances for your hybrids. This works really well, and it's extremely fast. So anyway, that's what I wanted to show on this. Any questions? Yes? Mm-hmm.
So, I understand you're scanning in the mouth, working directly in the mouth, that's articulator. But you do mount that on an articulator, correct? After you
No. So what I'll do is I will usually print, if I really wanted to, yes, you can. But what I usually will do is I will print a model, a solid model, and then just try on for like fit, just to make sure things like fit. But the actual articulation is all done on the computer. So I don't use a physical articulator basically at all. That's my physical articulator.
It's all virtual.
Yes, and like I said, typically when you're doing that workflow where you take the new bite record at the final vertical dimension in the patient's mouth, the adjustments on these go to almost negligible. Like the picture I showed with the handpiece cassette, it was still in the wrap, because it just fits like, and I don't do any glazing and staining on these, right? I just polish these, on the occlusal surfaces. So everything that you've developed on the computer is what you get. Yeah.
I have a question.
Yes, sir.
It's about you.
Oh gosh.
As a technician before you become a dentist?
Yeah, I went to college, then went immediately to dental school, and then immediately to pros. But when I was in dental school, I did the thing that most Prost wannabes want to do, or that they do. Hey man, I'll do your denture wax up for you for $50. I'll do this wax up for you, for $30. I did that like when I was a fourth year dental student. I had like a ring, of people that would send me, like their denture wax ups. Made some good money. Just like side change. So, and I did do free clinic. So I worked 2 nights a week for 5 hours per night at the free clinic that was in Redlands. I went to Loma Linda University in California, which is like San Bernardino area. And I would work the free clinics doing removable. And so we did all of the associated lab work for that except for processing. Yeah. Any other questions? All right, very cool. Well, I appreciate you guys having me. This is fun, and next time I'll have more like on removable and some other things on like hybrids and stuff like that. So I always have stuff to talk about.
Thank you, Dr. Gary. That was awesome.
Yeah.
As always, it's very impressive. I need to take 10 seconds of your time before you walk out. Ivoclar is doing an innovation tour. The first stop is going to be in Dallas, April 19th and 20th. April 19th is for technical. The 20th is going to be for clinical. What the tour is about is they taken a big truck, wrapped it, and put all the brand new equipment and material in it, and they're touring the U.S. with it. Simply because we know the COVID's kind of hindering a little bit of the technicians, lab owners, lab technicians going to some conferences. So we thought we'll bring you the material to you, and they're going to have the stop after that in San Antonio and Houston, and the dates are.
Well, it'll be April 22nd in San Antonio, and then in Houston it is April 27th. It actually be 3 days in Houston.
So if you're interested, stop by our booth, pick up a flyer. You can sign up online. We have to give you time slots because of the COVID, and then at the end of the day, we are gonna have a reception. We'll get together with some drinks, and the location in the Dallas area is going to be at the Renaissance Hotel in Legacy West. Very nice place, and you guys do some shopping, buy a Tesla, go home.
We do have some free CE too.
Yeah, 2 hours of CE if you show up and take a look at the tool. So come by the booth, pick up a flyer, we'll get you taken.
You guys offer discounts for Teslas?
Absolutely. Absolutely.
And if you decide to come to San Antonio, we have the JW Marriott in the Hill Country, so we got a room block there as well, and Houston's in Post Oak. So exciting stuff.
Thank you again, Dr. Bowie. Good to have you with us. Thank you.